I'm Jillian Webster. I'm the specialist nurse for familial hypercholesterolemia. I'm actually employed by York Teaching Hospitals Trust, but I work in Calderdale and Huddersfield Foundation. So I provide the nurse-led clinic from Huddersfield Royal Infirmary. We have 4 hubs in North East and West Yorkshire, one here in Calderdale and Huddersfield, one in Leeds, one in York and one in Hull. And myself and my colleague Leeds in Leeds, who's Claire Burton, we provide service for West Yorkshire. So we cover Leeds, obviously Calderdale and Huddersfield, Wakefield, Bradford, all of Kirklees, and then out to Airedale as well. I have a clinic in Huddersfield, I run a clinic in Halifax, and I also do a satellite clinic out in Shipley. So that's the sort of a brief overview of the service. So what we're going to do today is we're going to have a quick chat about the definition of FH, what it is, talk about Simon-Groom criteria, which is still the criteria that we use for referrals and that we use for receiving referrals, but also to talk to you about the hopefully the new pathway that we're going to have, the referral pathway for specifically for FH, that will hopefully make things a bit easier, a bit clearer for us to receive those referrals and for you to be able to send them in to us. We have got some time built into the later on for chat about that, so any sort of questions, if you can put them in the chat and then I can come back to them. I can always go back to the slides as well if there's anything in there particularly that you want to go through, and we can talk about those as well. I've got a few case studies for us to look at as well, and these are sort of real case studies that have come into the service over the past few years, and how we sort of triage them and take them forward as to whether they're FH or not. And then just a little bit about when is FH not FH. So there we go. So what is FH? It's a genetic disease which results in reduced clearance of the LDL cholesterol in the blood and an increased risk of early heart disease. So people with FH have elevated LDL cholesterol levels from birth, and this is really important. It doesn't suddenly appear that they've got high LDL. They have that from birth and it goes up over time. And we know that children with FH show an increased thickening of their arteries compared to their non-FH siblings normally by the age of about 11. And that shows us that process of atherosclerosis develops early in life and starts early in life. So as a result of FH, the incidence of fatal or non-fatal MIs without treatment, so this is if we haven't found people with FH and we haven't started treating them, by the age of 50 in men, about 50% of them will have had some sort of cardiac event. And for women by the age of 60, about 30% of them will have had some sort of cardiac event, and that is normally an MI. So again, what we're looking at different types of FH. By far the most common FH type that we see is the heterozygous FH. And that affects about between 1 in 300 to 1 in 250 of the population. And heterozygous FH means that they've inherited one copy of one gene from one parent. We do see some compound heterozygous FH patients. I think I've probably got about 2 or 3 families with compound heterozygous. This is obviously much rarer. This is about 1 in 800,000. And this occurs when a person inherits one gene alteration from one parent and another gene alteration from the other parent. So they've inherited FH from both parents, but it's a different gene alteration from both parents. Homozygous FH is very rare, about 1 in a million, and this occurs when a person inherits 2 copies of the same gene alteration from both parents. So they inherit 1 copy from mum, 1 copy from dad, but it's the same gene alteration in both parents. So rather than the different ones that they inherit in compound heterozygous, it's exactly the same gene gene alteration from both parents. We also need to look at the genes affected, because this can have a bearing on what we actually find when we're looking at the genetic reports and what that actual genetic report means. By far and away, the most common genes that are affected by FH are the LDL receptors, and about 95% of the genetic testing that we do, they come back as LDL receptor gene mutations. And again, that's important to remember, just keep that at the back of your head, that it's that LDL cholesterol that causes problems for our patients with FH, and it's that LDL cholesterol receptor that about 95% of them have a mutation in. About 4% are what we call ApoB1s, and 1% are the PCSK9 gene that would be affected. But by far and away, the most common ones are the LDL ones. We're going to concentrate today mainly on heterozygous FH, and essentially that's because they're the most common ones that we have. They're the most prevalent ones that we see. So FH is, as we know, an autosomal dominant disorder, and that affects about 1 in 250 people, as I've said. Most people with FH are undiagnosed. Currently, the national figure, about 12% of cases with FH. We know about 12% of the cases with FH. In the West Yorkshire region, it's slightly lower. It's about 10%. And if we look at the population, if we took the population of the UK as maybe 66 million, that means that just over 250,000 people would be expected to be affected by FH. The NHS long-term plan from 2019 set out aims to increase this diagnostic finding up to 25% over the next 5 years. So that brings us to 2024. So the aim was to have found 25% of people with FH by 2024. Now, this hasn't happened, and it is not going to happen, quite bluntly. A couple of reasons for this. The main one has been the COVID pandemic, to be perfectly honest with you. And this meant that probably about 18 months, maybe 2 years worth of referrals that we would normally get into the service, testing that we would normally do in the service, that hasn't happened. And sort of the knock-on effect for that is that people have not been having their NHS health checks, so we haven't found anybody from those for about a couple of years. About 50% of our referrals come opportunistically from things like NHS health checks, from people having the cholesterol checked elsewhere, so some workplace testing that had been going on hasn't been going on either. So as with pretty much all our areas of healthcare, the COVID pandemic's had a massive impact on our ability to actually identify people with FH. So as I've already said, each affected person normally has one affected parent, and that's our heterozygous FH. But what we need to remember within that figure is that each child and sibling of an affected person also has that 1 in 2 chance of inheriting the gene. So they've also got that 50-50 chance of inheriting the gene. Males and females are equally likely to be affected. So it's not one of these disorders that just tracks down the male line or just tracks down the female line. It's passed on and inherited equally between the genders. And ethnicity is not thought to be a factor, although having said that, we don't have any definitive studies that tell us whether it is or not. And most of the population in sort of the European FH population are Caucasian. So that's a lot of the figures are based on that sort of Caucasian population as well. So it's just maybe to bear that in mind as well. So this is a typical sort of family tree of a family pedigree for FH, and we are going to come on to some case studies later on where we'll maybe sort of be able to put this into our heads as to where things happen. So our first generation here, we've got a male here with FH at the top, and he has 3 children, one of whom has inherited the FH gene. So this male here has inherited the FH gene. He has 3 children. So his daughter here has inherited the FH gene. His son here has inherited the FH gene. and this son here hasn't inherited the FH gene. His daughter has 2 children and both of them have inherited the FH gene. His affected son has 3 children and 2 of them have inherited the FH gene. And obviously his son without FH, we don't need to test his children, because if he hasn't got FH, they can't inherit it from him. Now, obviously, we don't know about his wife's side of the family. It may be that there's FH in her side of the family, in which case we would test the children, but we would test them from her family tree. So in this particular family tree, these are the people that we're interested in here. And I spend quite a lot of my clinical time working with families, drawing family trees with them, drawing pedigrees with them, and showing them how FH is inherited and whereabouts in their family tree we need to test next, basically. So, talking about the Simon-Broom criteria. So this is hopefully common to you all. We all know about the Simon-Broom criteria, and again, it is still a valid tool for assessing somebody for FH, and still a valid tool for referring patients into us with suspected FH as well. So I'll just go through this quickly. So definite FH is defined as a total cholesterol of greater than 6.7 or an LDL above 4 in a child under 16, or a total cholesterol over 7.5 or an LDL above 4.9 plus, and this is the important thing, it's not just the cholesterol, it's a plus and an or. So plus tendinxanthoma in the patient, or in a first degree relative, or in a second degree relative. I'm going to come on to show you some pictures of tendinxanthomas later on, and just to be sure that we're all sort of aware, tendinxanthomas are completely different to xanthelasmas, and I will show you that in the pictures as well. So xanthelasmas do not give us that definitive answer for FH. So we're looking at that high cholesterol plus the tendinxanthoma, or the high cholesterol and a DNA-based evidence of one of the mutations. So they've already been tested and we know they have it, basically. So that's definite FH. By far and away, the most common referrals that we get in are the possible FHs. So the possible FHs are those cholesterol figures that we've just talked about. So that high cholesterol there, so the total cholesterol over 7.5 or an LDL over 4.9 in an adult, plus family history of MI below the age of 50 in a second degree relative, or below the age of 60 in a first degree relative. And that's really important. It's that premature cardiovascular disease, that premature MI, that's the important factor for us to be able to triage whether we think that might be FH or not. Or a family history of a similar raised cholesterol, and that similar raised cholesterol are the same sort of figures that we see right at the beginning. So it's not necessarily an easy criteria to look at, but what I tend to ask people to remember is that if you've seen somebody with that really high cholesterol, so that cholesterol over 7.5, and they've got a family history of that premature cardiovascular disease, that would be enough for you to be referring them in to us. What we then want to have a look at are some of the other sort of nuances, really, that we might to triage them with, or that we might see them. And the FH pathway is hopefully going to be able to help us triage that a little bit better and get those referrals a little bit more refined, if you like. So here are our physical signs of FH. So we've got the tendinxanthomas, and these are our Achilles tendons. I have seen maybe 10 or 11 of these in clinic in the whole time that we've been sort of running the service, and that's over 6 years. And once you see them, it's very definite. It's very definite what they actually look like, and it's quite sort of marked. B, we sometimes see the extended tendons of the hands as well. So you'll see cholesterol deposits along the back of the hands here. And and sometimes we see them in elbows as well. We might see those in sort of elbows as well. At C, we've got the xanthelasmas that I was talking about. Now, these are the cholesterol deposits in the eyelids, under the eyes here. And often we will see those in older patients who've got a raised cholesterol, but not necessarily because of FH. And that's why we need to be a bit more careful with the xanthelasmas. If somebody under 40 has these marked xanthelasmas and they've got that high LDL cholesterol, then that's potentially another reason for referral in, and I'll come on to that in a moment as well. But often patients sort of 50 and over who've got the xanthelasmas, it's a diet and lifestyle related. It's because they've got high triglycerides as well, and that's what's causing these cholesterol deposits. So xanthelasmas are not normally included in our criteria, our referral criteria. We do see corneal arcus. I've seen maybe 3 or 4 premature corneal arcus, and again that's under the age of 40, because again it's something that can happen over time. So anybody sort of over 60 with corneal arcus, we maybe would not think that that was FH, but we would want to look at the other clinical signs as well. So we wouldn't say definitely no, but we would look at the other clinical signs as well. I have had 3 patients referred to me with corneal arcus by our optician friends, and all 3 of them were found to have FH. So the opticians picked up the corneal arcus when they saw them and referred them into the service with a cholesterol profile as well. So these are the sort of the physical signs to look out for. We can come back to these in the chat if anybody wants to have a sort of a bit more of an in-depth discussion about those and what we're looking for and what we might be sort of thinking we might see there as well. So this is the FH pathway as it is at the moment, and I'm hoping it's going to stay this way. We've had several revisions of it, mainly because it isn't straightforward. It's not a case, it's not as simple as case as you know, somebody's got a high cholesterol and somebody might have had a heart attack in the family. It's a little bit more complicated than that. So at the top here, we've got the patient under 30 and a total cholesterol over 7.5 or an LDL over 4.9. Confirm this by a fasting lipid profile. And the reason we need it to be a fasting lipid profile is because we get an accurate LDL cholesterol and we also get an accurate triglyceride profile at that. And it's the triglycerides that tend to be the sticking point for quite a lot of referrals that we get in. Quite a lot of the referrals that we reject and say we can't send them for FH testing are because they've got high triglycerides. So that's why we're asking for a fasting extended profile to confirm that. We'd then look to see if they've got any of the tendon xanthomas. And again, tendon xanthoma is the Achilles tendons, the tensors on the back of the hand, sometimes the elbows, but not the xanthelasmas, so not the deposits around the eyelids. If they've got tendon xanthoma, refer to the lipid clinic for evaluation. So that's where we go there. You refer them into the lipid clinic for evaluation. If they don't, we're then looking to see if they've got that family history of premature MI or hypercholesterolemia, and that's this box 2 here. So if they have, we then look at the fasting trig profile. Is it below 2.5? And the reason for that will become apparent in a moment when I show you the modified Dutch lipid network score. So we're looking at the triglycerides. If it's below 2.5, then refer into the lipid clinic for confirmation of their FH diagnosis. So again, we refer them in there. If the fasting trigs are above 2.5, we need to look at managing secondary causes. And these secondary causes are here in box 1 and box 1 star. So quite a few medications will cause high cholesterol, and there are quite a few secondary causes that will cause the high cholesterol, and specifically those high triglycerides. So things like uncontrolled diabetes, excess alcohol intake, obesity, medication-induced hypercholesterolemia, which is here at box 1 star, hypothyroidism, nephrotic syndrome, cholestatic liver disease. This is not an exhaustive list. However, if somebody's got those fasting trigs of above 2.5 and they do have one of these secondary causes, that's what we're looking at. We then ask you to reassess in 6 months, including again the triglycerides and an LDL. And then if there isn't any change or they're not responding or we don't see any difference in those measures, it is unlikely that it's FH. It is unlikely that it will be of FH. It's more likely that it's one of these causes here. But we can still refer into the lipid clinic for evaluation. So if we've managed secondary causes, we've reassessed in 6 months and the trigs and their LDL are still not responding, so they've still got those high trigs, refer into the local lipid clinic and we will look at them in the lipid clinic. Just as a side, if the fasting trigs are above 4.5, none of the labs can actually give us an LDL valuation. So we don't get an LDL valuation if the trigs are above 4.5. And that's another reason why managing it, getting those trigs down will give us an accurate LDL profile. When we refer into the lipid clinic, so if you refer into the lipid clinic, each of the lipid clinics has somebody who does the triaging for those. We don't have a specific FH referral pathway, so you can't refer directly into the FH service. It has to come via the lipid clinic. There are 4 of those again for us to refer into. So there's the Leeds, Colesdale and Huddersfield, the Hull one and the York one. And the next page is going to show you all the contact details, which will be on the back of the FH pathway. I do all the referrals and triaging for the CHFT service. So any of the referrals that come into Colesdale and Huddersfield, I do the triaging for those. If they fit the criteria for genetic testing for FH, I will then move them into my workflow, and anything else stays in the lipid clinic referral pathway for the lipid clinic clinicians to have a look at. We can revisit this in the chat. We can have another look at this in the chat. I know it's sort of quite a brief look at the moment, but what we're saying is still look at Simon Broom, but also look at the FH pathway and see if that makes it any easier to sort of sort that referral out, really. So these are the contact details on the back of the FH pathway. And important to mention as well, we do have an LDL correction factor for patients who are already on cholesterol lowering medication. So sometimes we'll get referrals in and they're already taking a TARV 20 or a TARV 40, and we can actually do a correction table to tell us what their untreated LDL cholesterol would be. And that's often really important because that will then help them score high enough for them to get genetic testing, basically. So this is the other criteria that we use, and you might be familiar with this, you may have seen this. This is the Modified Dutch Lipid Clinic Network score. And when we have a look at some case studies in a moment, we're going to use this to actually score the referrals, and they're all actual referrals that came into the service. So we'll use this to score the actual referral. So here we have in family history, we get points and you circle a box in each of these boxes, if you like. So family history. So first, second degree relative under 60 with oopsies, with no premature CHD, or under 45. So if they're under 60, they score 1 point here. If they're under 45, they score 2 points here. Or it might be that they've got a high cholesterol. So we know that they've got that high cholesterol over 7.5 and they would score 1 point. Or if they're under 18 and they've got that total cholesterol over 6.7 or an LDL over 4, they would score 2. So you're only ticking one box here. So this is out the family history. The patient themselves, if the patient themselves has got tendon xanthoma, they would instantly score 6 points for that. So we would automatically be testing them because they've scored 6 points or more. And if they've got premature corneal arcus, and again, this is sort of anybody under 40, We can use a degree of sort of clinical decision making there, and if maybe the sort of early 40s and they've got a really high LDL, we would probably still want to test them, but they would score 4 points here. The patient's own clinical history, so if the patient themselves has had premature CHD, if they're under 45, they score 4 and continuing all the way down, so under 50, 3, under 60, 2, and there is a score that would score at 1 point if they've got premature, if they've had strokes or they've already got peripheral vascular disease. So we're taking into account their own cardiovascular history as well. The most important box really is this one here where we're scoring their LDL cholesterol. So an LDL above or greater than or above 8.5 would score 8 points. So we would automatically want to put them forward for genetic testing, irrespective of what they're scored elsewhere on here. An LDL cholesterol between 6.5 and 8.4, they would score 5 points there. LDL between 5 and 6.4 is 3, and an LDL between 4 and 4.9 would be 1 there. And then importantly, and this is again why the triglycerides are important, and this is really another one of the reasons why it's important that we know what the trigs are and what their LDL is that they score minus points for high trigs. So if the trigs are between 2.5 and 3.4, we would need to take 2 points off the total score that they've got here. If the trigs are between 3.5 and 4.9, we would take 3 points off. And if the trigs are above 5, we would take 4 off. But as I've already mentioned, if the trigs are above 5, we wouldn't have an LDL measurement for them. So it is quite complicated, but having said that, once you've looked at them, once we've looked at them, you do get a feel for what's going on. You do get a feel for sort of which numbers add up to 6 and above and which boxes they're scoring in. We do sometimes see patients who don't know their family history, and that's quite common. So we do see patients who don't know their own family history. And again, what we would do there is we would make a clinical decision based on the other parts of the boxes or the other parts of the pathway. So say somebody doesn't know the family history, but they've already scored 5 here because their LDLs say 7. And they've scored 5 here, but they don't know their family history for whatever reason. Sometimes patients are adopted, sometimes we've got those family breakdowns where they don't know, or sometimes the parents have died before they know anything about the family history. If somebody scores 5 on their LDL alone, we would look at the other scoring, and we would normally make a clinical decision as to whether to offer them genetic testing or not. Depending on their age as well, that would make a difference. And I have to say, if we've got somebody who's got an LDL and they score 5 on that, but we don't know a definitive family history, we would normally put them forward for genetic testing. So we would normally see them in our clinic and offer them genetic testing. Excuse me. So we'll have a quick look at a few case studies and see how we get on with that. So this first one, 65-year-old female, she's got no personal cardiovascular history, no family history that she knows of, and she had a non-fasting lipid profile in 2017. Total cholesterol was 8.4, LDL was 5.7, trigs were 1.4, and Q3 was 10.25. So she does need something doing because of that Q risk. But what we're actually looking at is whether it's an appropriate FH referral and whether we would be offering her genetic testing or not. So she actually scores 3. She only scores 3 on the Dutch lipid score, and that's because, that's because of her LDL, but also that family history. So the recommendations for this patient were, and like I said, these are all actual referrals that came into the service. So first of all, we'd like an up-to-date fasting lipid profile because we need to know what that LDL and what those triglycerides are on a fasting profile. We'd also want to confirm the absence of cardiovascular disease and the cholesterol over 7.5 in the family. We'd give her general lifestyle advice and we'd commence and titrate statins. For her, it's unlikely that it's FH. Her modified score is only 3, so we wouldn't be recommending genetic testing for her. So our next case study then is a 41-year-old male, excessive levels of alcohol consumption, and that's above 28 units a week. His blood results were from 2021. His total cholesterol was 7.7. His LDL cholesterol was 5.2, and his triglycerides were 2.7. ALT was 355 and his gamma GT was 128. We don't know anything about his family history. We haven't got that recorded. And again, that's one of the problems that we see, and we know in primary care that we don't always have those complete recordings because patients either don't know or they haven't got that information. So that's something else. Sometimes it's to do with coding as well. It hasn't necessarily been maybe been coded. So this referral, based on the information that we were given, this is what we did with this chappie here. So he's got 1. Recommendations were lifestyle advice focusing on the alcohol, and that's likely to be the cause of the raised triglycerides and therefore the raised total cholesterol profile. We'd want to repeat a full lipid profile after a period of abstinence, and we'd normally say probably 6 months if possible on that, and then repeat his full lipid profile at that point. Again, confirm that personal and family history of cardiovascular disease and high cholesterol just to make sure that it's not there. Having said that, even if we did have that, he would still not be scoring highly enough for him to be tested there. So even though this chappie did fit Simon Broom criteria because his cholesterol was over 7.5, we're not sure that he did fit the Simon Broom criteria in the first place because there was no family history recorded and we didn't know about the family history. So it's those 2 things together. It's that family history and the total cholesterol together that we look at. Oop. Sorry, it's frozen. So our next one then. Oh. So 36-year-old female. First found to have high cholesterol in 2007 at the age of 28. She came to the GP's attention in 2015 because despite taking simvastatin 40, her cholesterol was still 6.6 and her LDL cholesterol was 3.9. She's in between that, she's had an off-treatment lipid profile done in 2014 when she was pregnant, and her cholesterol then was 9.5. She had an LDL of 7.2, HDL of 1.6, and trigs of 1.4. Family history included, Dad had high cholesterol, so similar high cholesterol over 7.5. Her paternal grandfather had died in his 50s from an MI. Maternal grandmother had died in her 50s from an MI. So we've got the high LDL cholesterol here, the trigs below 2.5, and a family history which includes high cholesterol in her dad and also that premature cardiovascular disease in 2nd-degree relatives. So what did we do with her? Okay, so you can scan. Oh, there we go. So she scored 6. So her modified lipid score was 6. So we offered her genetic testing for FH, and the results confirmed that she did have a heterozygous LDL receptor gene mutation there. So heterozygous, she's inherited from one parent, and that LDL receptor mutation. So after she completed a family, she restarted back on lipid-lowering therapy of a Torva 40 and ezetimibe 10 milligrams, and her cholesterol came down to 4.7 her LDL 2.6 and her trigs down to 1.2. So she'd achieved the 50% reduction in LDL as recommended by NICE. Now, those recommendations have recently been updated, only in 2023, where we follow the European guidelines now, and there is a reference to those in the references at the end if you want to have a look at those. And what we're actually looking at now is, rather than a 50% reduction, we're aiming to have an LDL of 1.7 and below for patients with FH who haven't had a cardiac incident. And that LDL cholesterol should be 1.4 or below in patients who have had a cardiac incident. Now, those are really quite low levels to achieve, but we do have quite a lot more pharmacology available to us now that we can use to help patients get their cholesterol down. So today's talk not really about those, although I'm hoping that we'll be able to do one at a later date that talks about the new medications and pharmacology and that sort of thing, specifically for our FH patients. So our next case then, so she had a daughter whose cholesterol was 7.2 at the age of 8 and an LDL of 4.8, and a son whose cholesterol was 8.2 and an LDL of 6.5. And both of her children have been confirmed to have FH, and they're under the care of the paediatric metabolic team. These cholesterol levels are not unusual in children. We do see those high cholesterol levels in children, and that's like I was saying right at the beginning, that it starts from them being born, and that cholesterol goes up and up and up. And as you can see, if we don't halt that, if we don't get that cholesterol down, that's when we're looking at really early cardiovascular events for them. So our next case study then, a 42-year-old female, her brother, who was 39, died suddenly, and his post-mortem confirmed that he had extensive cardiac disease. The mum had been on statins since her 20s, and this female's lipid profile at referral in November 2020, her cholesterol was 11.5, her LDL was 9.3, HDL 1.6 and trigs 1.4. So she'd had a lipid profile in March 2013 where her cholesterol was 8.9, LDL 6.6, trigs 1.1. And the comment in GP records was that it may be that cholesterol is raised due to hypothyroidism, which is absolutely a correct assumption to make. And certainly many symptoms of enlarged thyroid try increasing levothyroxine. Unfortunately, this lady had not then had another cholesterol profile done, so her cholesterol profile had not been rechecked again until she had the one done in 2020, and that showed a DLCN score of 10. She was offered genetic testing for FH, and the result confirmed a genetic diagnosis of LDL. So that was a heterozygous LDL receptor mutation. She was started on lipid-lowering therapy of atorvastatin 80 and ezetimibe 10. And her new results then in January 2022 were that cholesterol was 4.2, her LDL was 2.3 and her trigs were 1.3. So again, she'd achieved the more than 50% reduction in LDL as recommended by NICE. But again, now we will be looking back at her and trying to help her reduce her LDL cholesterol a little bit more there. Both her children were found to be negative for the LDL receptor gene, but her niece is found to be positive. So her niece is positive for FH. So there's some sort of real life examples of referrals that we've had into the service, and what we've sort of done with those, and why it might be that you'll see us saying, yeah, this might not be FH, can you do this or can you do that? Oh, I've lost my little mouse. Come on, where are you? So we're gonna, hopefully, I've got a couple more slides for us to have a look at, and then we can go to some questions. So why is it important that we establish that genetic variant? Why is it important that we do this genetic testing? Obviously, for being able to cascade our relatives, that's one of the main aims of our service for our pharmacological treatments, but that cascade testing for relatives is really, really important. If you remember that each person with FH, every sibling they've got, every child they've got a 50-50 chance of inheriting FH as well. That's a lot of people out there with FH that we haven't found yet. Establishing a genetic variant helps us to target those appropriate preventative strategies, and it helps us to identify genetic and non-genetic causes of cardiovascular disease. So that wider picture of cardiovascular disease and what's causing that. It also helps us to be able to provide appropriate lifestyle advice. And then the pharmacological treatments that we can offer, we've got the statin therapies, we've got PCSK9 inhibitors, bempedoic acid and inclisiran. So we've got a few more things that we can actually offer our patients with FH if we know that it's FH and we've got that genetic diagnosis of FH for them. Some ethical issues, so things that we think about before we actually do the genetic test, or things that we do within our appointments when we're talking to them about genetic testing. Those implications for their family, especially where we've got family breakdowns or where we have those sort of family dynamics where one branch of the family doesn't talk to the other, or that and vice versa, those sorts of things, they can be quite difficult for families to talk about. Things like employment or insurance, they do have implications for both those. We're always mindful that a referral into the service doesn't necessarily mean that they will have that genetic test. They are at liberty to decline that testing. Often those family breakdowns will sort of precipitate that as well. We have those sort of feelings of guilt and stigma and blame. So I've got an inherited condition, I pass it on to my children, that sort of guilt that's associated with that. And then we have that sort of anger and sadness that comes along with that. There's also, you know, are they 100% accurate? It is a very specific test, and they are probably about 98-99% accurate, but actually there are some that fall outside that maybe are not accurate. And then we've got that whole sort of big package of lifestyle changes that we're expecting people to make as well. And once they've found out that they have FH, there's no going back from it. They can't unfind that out, basically. So we'll have a little look at any questions that might have come in, if that's okay. So when is FH not FH? Let's have a look at the questions then, shall we? Let me see if I can stop sharing.
So we have two. The first one is, what does the modified score need to be for genetic testing?
6 or above. So it needs to be 6 or above. Oh, I can't unshare now. Sorry, I'm trying to unshare. There we go.
The second one is, if statin's not tolerated, would you consider bempedoic acid plus ezetimibe?
We normally recommend, if you've sort of challenged with 3 statins, so we've tried the 3 statins, so normally atorvastatin, we can go rosuvastatin, and often simvastatin. So if we've had 3 challenges with that and they are intolerant to those, we would normally recommend an initial referral into the lipid clinic for that expert advice, and that might be an advice and guidance, that it could take the form of an advice and guidance, or the lipid clinician might want to see them in lipid clinic and have a discussion with them, but that's essentially where we'd go with that.
That's lovely, thank you. Does anyone else have any questions?
Are you all stunned now?
That's a really great session, Julie. Thank you. While people are potentially typing, I'm just going to include the link for the feedback form.
Brilliant, yeah.
So if you could fill it out, we'd really appreciate it. It just helps us shape future events and feedback around this one as well. So does anyone else have any more questions? Okay. If not, I'd just like to thank Julie so much for speaking today. It was really informative, so thank you very much. If you do have any questions that you think about afterwards, please do just send them through and I can pass them on. Oh, we do have one. So still a bit confused postmenopausal high cholesterol.
Again, a difficult one. I mean, I'm just here to speak about FH, so I'm just here to talk about the referrals to the FH service. We do sometimes see patients with that really high cholesterol, and it is menopausal. But what we need to remember is it's that LDL cholesterol that we're looking at. So if that LDL cholesterol is fitting within those parameters, so if they've got an LDL cholesterol over 6.5, they would score 5 on the Dutch Lipid Clinic Network score. So they would score a 5 there, and we would make a clinical decision then as to whether we needed to test them for FH as well. What we don't want to do is miss people out. We don't want to sort of discard people who've got a high cholesterol for other reasons, but actually they could also have FH. So that's the problem, really, I guess. If they're scoring 5 on the Dutch Lipid Clinic Network score, so they've got an LDL over 6.5 and they've got trigs below 2.5, I would still say refer them in, and we can make that clinical decision as to whether we think they would be appropriate for testing or not.